I know you're a pro at this. Batteries changed. Good to go.
I got it. Good morning. So nothing to disclose again. People spend a lot of time looking for bleeding disorders, usually for not any particularly good reason. Two essential points are the really weird stuff, the stuff that people are born with, like hemophilia and von Willebrand's disease. These are common. I'm sorry, these are uncommon. These are even rare. Great, now you're all going to fail. Whereas acquired bleeding disorders, like taking aspirin or drinking too much alcohol, these are common. So, as you've heard before, when you hear hoof prints outside the window, it's not a unicorn or a Pegasus, it's a horse. So when you're evaluating patients for bleeding disorders in the upcoming years, don't start by looking for a factor 11 deficiency. Start by asking the patient what they're putting in their mouth, thinking about the patient's renal function and so forth. As I mentioned yesterday, really a basic assessment of hemostasis, a patient's ability to clot properly. You don't check all of their factor levels. You don't do a bunch of fancy tests. You start with the PT, the PTT, and the platelet count. And that will solve the majority of actual bleeding cases. Occasionally, again rarely, with a patient with a bleeding disorder, you need to replace what they're missing. They have a factor that's missing, you have to replace it. Their platelets aren't functioning, you have to transfuse platelets. But this is really uncommon. Usually in patients who are bleeding, there's an underlying disorder. You have to identify what it is and fix it. So really, one of the most powerful tools that you can use is to take what we call a bleeding history. And what's the worst question you can ask when you want to see whether or not someone's really got a bleeding problem? It's bruising. I get patients all the time who are easy bruisers, and I won't embarrass anybody here, but if I asked how many of you are easy bruisers, half of you would raise your hands, but half of us are not easy, don't have bleeding disorders. So, especially in women, when women will declare themselves earlier than men for obvious reasons, ask about, people don't necessarily compare their periods to each other. Ask, have you needed iron because your periods are so heavy? You can actually take a very detailed menstrual history and be able to compare it to other people, and that might be a clue for a bleeding disorder. Family history is very important. If people are bleeding to death or bleed a lot in the operating room table, then that might be a clue that this patient might have something in the family as well. By nose bleeding, I don't mean the same nose bleeding that we all get in the winter when the heat's on full blast in New York City apartments and our nasal mucosa dries out. I'm talking about people who bleed for half an hour on end for, not because they're picking their nose, but for no reason whatsoever. Did you need a blood transfusion for some reason? This, again, might help you, work this out. Have you ever given a dentist a heart attack? They took out a tooth. We tell dentists to have, to remove patients' teeth when they're on blood thinners now, because it's actually not dangerous at all. But if a patient reports to you that, that they scared the death out of a dentist because they couldn't stop bleeding, that's a clue that there's a bleeding disorder. Hematologists have actually spent a lot of time trying to develop questionnaires, that will kind of very well predict who has an inherited bleeding problem or any kind of bleeding problem, and they're not particularly good. But these are the questions you might ask, and again, bruising is a worthless test or a useless question to ask about. So we're going to go through the most important bleeding disorders now. Does anybody speak Aramaic here? Or read Aramaic here? There's a few of you out here. But about a little bit less than 2,000 years ago, a bunch of rabbis were sitting around and debating how many times you had to let a male child in a family die during their circumcision before you could actually tell the parents that they no longer had to try to circumcise their child on the 8th day of life, which is an ancient Jewish custom going back more than 3,000 years or so. And this quote from the Talmud is basically the earliest description of hemophilia. And the majority, it's interesting, if you read the Aramaic, the majority opinion says, well, once two boys die, you don't have to circumcise the third one, but there's a dissenting opinion that says, actually, you have to let 3 die. And if the third one dies of bleeding, then you don't have to circumcise the 4th one. So this is the earliest description of hemophilia, and it mentions boys because boys were exposed to this hemostatic challenge earlier than girls, and because hemophilia is X-linked. So, as I mentioned yesterday, about 80% of hemophilia is congenital deficiency of factor VIII. and the remaining 20% of it is congenital deficiency of factor IX. They are indistinguishable from each other, largely because the two of them combine together when they're activated to form the tenase complex. And so you cannot look at a person and tell what kind of hemophilia they have, but obviously you may know based on family history. It's X-linked, and you'd be shocked at at how patients sometimes don't know their own family histories that well. And so, what's important sometimes. What's important is that I pick a color. All right, we'll do green. Which is not unusual to see, is this individual right here. She kind of, for some reason, blanks out of the fact that she had a brother with hemophilia. He may have died at a very young age. And so, she marries somebody or has kids with somebody, and it's a total surprise when she has a son over here with severe hemophilia. For some reason, people don't necessarily make that connection. Lay people are not necessarily well-versed in understanding X-linked inheritance. Importantly, there is this woman right here who's got even though she's heterozygous, she's got 35% factor VIII or factor IX activity. And that's because you can get extreme lionization of the X chromosome, which favors expression of the bad copy of factor VIII or factor IX. And so there are a few women in the United States with severe hemophilia, and we have a few patients in our clinics here who have mild to moderate hemophilia because of extreme lionization. Kind of like the classic presentation is what we call hemarthrosis. You do see it in other conditions, but when you hear hemarthrosis, which is bleeding into the joint, you should think of hemophilia. These are other manifestations of it, and importantly, these things are unprovoked. This can lead to a lot of stress early on in life, because you can imagine, parents for the first time have a son with hemophilia. He learns to crawl, and then he learns to stand up and cruise, and then he's going to learn to walk, and the parents are terrified, of this boy bumping his head all the time. All the things, these things can occur. They can happen spontaneously, and they can cause tremendous morbidity and mortality. So the hemarthrosis, that's, if you look at the right knee right here, you can see that it's acutely swollen compared to the left knee. And again, for reasons that are not well understood, because this doesn't happen to patients who have other bleeding disorders, like von Willebrand's disease, the joints in individuals with hemophilia A and hemophilia B will just spontaneously start to bruise or start to bleed and become swollen. And this can become chronically debilitating over time. And this is what can happen. If you look at the knee and the ankle here, these are chronically deformed. They basically become frozen in place. And you need to do orthopedic surgery to actually replace these joints. And of course, what orthopedic surgeon wants to do surgery on a patient with a bleeding disorder? So at this point, we do everything we can to prevent this from ever happening in the first place. If someone shows you this on an exam, what do you not want to do to that right knee in managing it? You don't want to put a needle in it. It's the only thing that's worse than bleeding in a closed space is bleeding in an open space. So if you're in the emergency room and someone comes in and someone says, oh, let's put a needle in it, see if it's a hemarthrosis, don't do that. Bad things will happen. This eventually will stop by itself. This is just a spontaneous, it's not, it might be psoas muscle, but it's a gluteal hemorrhage. And again, this is not someone who fell, this happened spontaneously. This patient had these huge ecchymotic bleeding into muscles that just happened by itself. We classify hemophilia, the phenotype, based on the percent factor activity. And the important thing here is you don't need that much to actually have a fairly normal life. If you have 5% either factor 8 or factor 9 activity, that's enough that, under most circumstances, you won't bleed. People who have severe hemophilia under 1% activity, these patients require what we call prophylaxis. We give them regular factor replacement whether or not they're bleeding. People who have moderate hemophilia, between 1 and 5%, there's variable penetrance, and some of these patients need replacement factor regularly, prophylactically, and others do not. So, in the past 10 years or so, prophylaxis has become the standard of care in severe hemophilia. This is kind of demonstrated in randomized controlled trials in children. Rather than waiting for the hemarthroses to occur, which are incredibly debilitating, rather than waiting for trouble, so to speak, they would start, kids would, 6 months, a year of life, sometime early, would get regular factor replacement. With factor 8, it's 3 times a week, and with factor 9, it's twice a week, and this is based on its half-life. And this is great. This prevents a lot of the complications of hemophilia. Unfortunately, it costs more than $100,000 a year because a unit of factor costs $1, and it's exorbitantly expensive. We see patients who basically emigrate here from other countries with they don't have the same kind of resources that the United States have. When their parents see that they have a child born with hemophilia, they cannot afford treatment in their own country, and they emigrate here, and they get on Medicaid so that they can get proper treatment. On-demand treatment is what we give to patients when they're actually bleeding, or if they're about to have an operation. And I'm not going to teach you how we calculate all of this, but you take the patient's weight, you take, whether or not they're 8 or 9 deficient, and, is it just that they're having a tooth pulled or they're having neurosurgery? Depending on the kind of challenge that they're going to have, you may give them more or less factor replacement. Kids hate factor replacement. You can get them to do it maybe until they're teenagers, and then they just stop because it's not a pill, it's not a sub-Q injection. You actually have to take a butterfly needle and access a vein and infuse this. And so, as you can imagine, 2-year-olds are not particularly adherent to this. That you'll chase them all around the house trying to get the needle into them so you can give them factor replacement, and they fall and hit their heads. So, it's a huge challenge, and teenagers won't listen to anything. They would rather bleed than do what they're told. So, recently, there have been developed, they're calling them long-acting recombinant factors, but basically they take factors, they take recombinant factor 8 or factor 9, and they pegylate it, or they link it to an antibody fragment so that the half-life goes up, so patients don't need to get factor replacement as often. In general, this has kind of led people with factor 8 deficiency to getting treated twice a week as opposed to 3 times a week. People with 9 deficiency will still need it once or twice a week. So it's not a godsend, but, and this just really come out in the past year or two. So we're not really clear how much this is going to change therapy of patients with hemophilia. Importantly, no one knows whether or not these new products will change what we call inhibitor formation. Think about it. These kids are not born with factor 8 or factor 9, so their immune systems have never seen it before. And then you give this kid an infusion of it when they're a year old, and the immune system says, I don't know what the hell this is, and starts attacking it. And so you can, this doesn't usually happen, but we do see it in a significant minority of patients with hemophilia. And we call them inhibitors, and they just wreak havoc. They just because you can keep giving factor and the immune system can keep making more antibody to it. We usually measure how strong these are in what we call Bethesda units. You just do serial dilutions, 50%, 1/2, 1/4, 1/8, and so forth, to see how long it takes to kind of dilute things out. And when people have high titer inhibitors, because their immune systems have reacted to replacement factor, you have to give them specialized replacement factors and products. And it's not 8 or 9, it's other stuff. And if you think that that 8 or 9 is expensive, this other stuff is astronomical. And it's dangerous. These things can rarely spontaneously earn hemophiliacs, which is to say, like, you can get an immune disease when you're 80 years old where your body will start attacking factor 8, or pregnant women can get this also. But that's pretty rare. So prior to the 1970s, people generally died in childhood and late childhood from bleeding, from hemophilia. Once we got to the 1980s to the early 2000s, it was infections that killed these patients. What infections were they? HIV and hepatitis C. I mean, this is like a kind of a sad moment in the basically in medical care in the United States. But patients, until we had recombinant products, patients got treated with blood products from, basically from donors. And HIV was not identified until the early 1980s, and hepatitis C wasn't identified until 1989. So essentially, an entire generation of hemophiliacs got infected. It was very rare for patients who were getting factor replacement at this time to not get infected, and people got infected in other countries for longer than they did in the United States, and it's really it was a very sad thing, because these were essentially innocent children who picked up both of these infections at the same time, and there was very little that could be done for them because we didn't have antiretrovirals until a decade later. We don't see this anymore. The recombinant factor products really don't. The risk of viral infection with them is minuscule, basically zero. And so hemophiliacs essentially have normal lifespans now. We're actually seeing some hemophiliacs who are getting coronary artery disease, which would have been unthinkable 30, 40 years ago. The rare patients who do die of hemophilia either have bad luck in terms of traumatic bleeding, or they develop inhibitors, which again can be very difficult to control. So, who's ever gotten a cut here and put on their finger and put their finger in their mouth? So, this is, believe it or not, this is like an instinct that we all have. And you'll learn all about, when you learn neurology, we're all full of all these weird things that we do, which for some reason our body are hardwired to do to keep us alive. And so, a few years ago, some researchers in the Netherlands found that saliva actually has tissue factor in it. And as I told you, tissue factor is a very procoagulant protein that that turns on the clotting cascade. So if you live in New York City, you've been aware in the past few years of part of the New York City culture wars. There's a community of ultra-Orthodox Jews living in New York City who have a practice when their children are circumcised, they perform oral suction on the child after the circumcision, and a few children after this have died of herpes encephalitis that they got from the person who did this. And there's been tremendous debate about whether or not this practice should be allowed to continue in New York City, because you don't want newborns getting herpes encephalitis. And no one can explain where this practice comes from, but you can imagine 1,500 years ago, someone saying, well, if I cut my finger, I lick it and it stops bleeding. Maybe we should do this to prevent children from bleeding when they have circumcisions. So, just a thought. Von Willebrand's disease. Over here, tucked away in these little islands between Finland and, I guess this is Sweden, somewhere in old Europe, there are these islands where there was this Dr. von Willebrand who noticed in this, this very, very large family with a lot of consanguineous marriage, when their daughters hit menarche, they died of menorrhagia. And basically, he was able to identify, clinically von Willebrand's disease in this family where, it was like a quarter of people out of a kindred of 60 all had the disease. So it was described about 100 years ago. And again, the same cartoon. Von Willebrand factor is one of the first things gets recruited to a site of vascular injury. It binds to exposed collagen and then binds to platelets. It has 3 different functions. As I've mentioned, it binds to platelets, it binds to collagen, and it protects factor VIII from proteolysis when it's circulating. So, you can imagine why this is an autosomal dominant disease, because it has all of these important functions. Here's a cartoon. This right here is von Willebrand factor. Here is where it binds to collagen, and it binds to glycoprotein 1b on the surface of platelets right here. It is autosomal dominant with variable penetrance. It's the most common inherited hemorrhagic disorder. Importantly, it's autosomal dominant, not sex-linked, but the majority of people with von Willebrand's disease who are identified are women. And it's not that women have it more, it's just that more women are identified with it because of menorrhagia, because of heavy menstrual bleeding. You will learn about blood groups on Monday, and just like red blood cells have blood groups, von Willebrand's disease actually has the same blood groups also. And so most people with von Willebrand's disease have type O blood, because A and B are basically sugars. They're attached to red blood cells, and when they're attached to von Willebrand factor, they increase its half-life. As I told you, von Willebrand factor protects factor VIII from proteolysis. It increases its half-life. So you can imagine if you have von Willebrand's disease, you have low factor VIII levels. And factor VIII is in the intrinsic pathway. So people with severe von Willebrand's disease can have a prolonged PTT, but a very large number of people with von Willebrand's disease have a normal PTT. So don't assume with a normal PTT it can't be von Willebrand's disease. All of the things below are kind of the manifestations of von Willebrand's disease. I showed you that, that graphic before of von Willebrand factor binding to exposed collagen. So classically the disease presents with mucosal bleeding, like menorrhagia and dental bleeding, and easy bruising. There are multiple different subtypes of von Willebrand's disease. None of our fellows understand the subtype 2, so I don't expect you to. In fact, most hematologists don't understand subtype 2. What I want you to understand is that with type 1, you generally have decreased synthesis of von Willebrand factor. With type 2, it's not that you necessarily have decreased synthesis of it, it's that there's something wrong with it. You may be making a normal quantity of it, but it's an abnormal functioning protein. Von Willebrand type 3, you almost make no von Willebrand factor. It's a severe deficiency, and it's extremely rare. 80% of von Willebrand's disease is this, and that's what you should focus on understanding. And all you need to know about type 2 is that it is a qualitative defect more than it is a quantitative defect. Again, these are multimers, and this is a normal patient, and you can see multimers of all different sizes here. And a patient with type 1 disease has all the same multimers as a normal person, but less of them. There are 3 different tests that we check, at least or 4, when we are assessing someone for von Willebrand's disease. One is we look to see just how much von Willebrand factor we have. We just count how much there is there, and that's called the antigen. And we count how much factor 8 is around, because sometimes when von Willebrand factor isn't, if you don't have enough of it, you're not going to have enough factor 8 either. So you look for the amount of antigen for both of these. The test for how well von Willebrand factor works, its activity, it has a weird, funky name called von Willebrand factor ristocetin cofactor activity. Ristocetin was an antibiotic that was, I think, discovered in the 1950s. And when they started giving it to people, they started noticing that it made them thrombocytopenic. And eventually people understood that ristocetin, this antibiotic, caused platelet aggregation. But the only people who didn't get platelet aggregation were people with von Willebrand's disease. It took a few years to get this observation right. And so ristocetin is basically a substance, we don't use it as an antibiotic now for obvious reasons, which induces platelet aggregation in the presence of von Willebrand factor. So you can use this as a surrogate to see how well your von Willebrand factor is functioning. It's a functional assay. And so, just very importantly, in people with type 1, all of these things will be decreased equally. And the way you differentiate type 1 and type 2, you will not be tested on this. In type 1, the reduction in antigen and activity are kind of in parallel to each other. Whereas in type 2, where I told you it's a qualitative more than a quantitative defect, you have a greater decrease in activity compared to the antigen level, and so the ratio between the two is less than 50% rather than greater than 50%. You will not be tested on this. I just want you to kind of understand it and nod to me during the lecture. And with some types of type 2 von Willebrand disease going back, you may just be missing high weight multimers, like you see in this patient here with type 2A von Willebrand's disease. So again, you might have enough von Willebrand factor. There might be tons of von Willebrand factor up here. It might be comparable to the total amount of von Willebrand factor you have in this gel. But if you lack the high weight ones, you're still susceptible to hemorrhage. Again, this is not a severe bleeding disorder like hemophilia. Patients just don't, it's not generally a lethal disease like hemophilia used to be. Often these patients require no treatment. For patients who have mild disease, we will give a medication called aminocaproic acid. This is a medication that inhibits fibrinolysis, that inhibits the breakdown of blood clots. It stabilizes blood clots. And so you can give it to a patient after they've had a dental procedure, and it will prevent the gums from oozing for a while. You can give it to a woman with heavy periods, and it will decrease her menstrual blood losses. I don't think you've learned about DDAVP yet. DDAVP is an analog of vasopressin, which is a natural pressor that the body makes, and this is a doctored one that's had 2 moieties changed. And this doesn't have pressor activity like vasopressin. What desmopressin will do is it will cause the body to release factor 8 and von Willebrand factor from the endothelial stores. So, because the endothelium always has factor 8 and von Willebrand factor stored up in there. And when you give desmopressin, DDAVP, you can get forces into circulation. And so if someone's going to have an operative procedure, you can give them this an hour beforehand. Their levels will go from, say, 30% to 150%, and they'll get the operation safely. There are concentrates of von Willebrand factor. And on Monday, you'll learn about something called cryoprecipitate, which is basically a blood product which is very rich in von Willebrand factor. Most people You can manage them with everything to the left of this green line here, and don't need these things. It's rare for people to need this kind of treatment. Factor XI deficiency is sometimes called hemophilia C, but it's different than the other two because it's not sex-linked and it's autosomal recessive. Again, factor XI is in the intrinsic pathway, so when you're deficient in it, your PTT can become prolonged, but there are lots of people with factor XI deficiency out there who have normal PTTs. These patients generally have these patients actually have no bleeding phenotype until you accidentally take them to the operating room and you're not paying attention to their pre-op blood work and they bleed a lot on the operating room table. There are a lot of families where one person is identified as having this and then everybody else gets tested. But often this is just kind of picked up incidentally in the operating room, or a patient comes in with an asymptomatic prolonged PTT and then they're tested for this. The only treatment for this is human plasma, really, in the United States, which you'll learn about on Monday. And this is most prevalent in Ashkenazi Jewish populations because of inbreeding over the past few thousand years. So it's most prevalent in Israel. Vitamin K, I was telling you yesterday, is extremely important. When I studied this for the boards, they said vitamin K is for coagulation, and they spelled coagulation for a K to help me, to help you remember it. And so all of these proteins down here require vitamin K as part of their final step of chemical modification before they're ready for prime time, so to speak. And so there is a carboxylase that basically requires vitamin K to give you the active zymogens of these proteins. And so if you don't have enough vitamin K around, you can get deficient production of these proteins, which sometimes can lead to a mild bleeding deficiency. The medication that you'll learn about on Monday, warfarin Coumadin, which for decades was the most common blood thinner that we used, kind of exploits this by poisoning our ability to use vitamin K so that, so it functions as a blood thinner. Vitamin K comes from our diet, especially from leafy greens, but from other things. It also comes from the bacteria that live in our intestines. So the people who we really see with vitamin K deficiency are patients who've been in the intensive care unit for 2 weeks because they've been exposed to 5 different antibiotics and they haven't had a meal in 3 weeks. And this completely depletes their vitamin K stores. And so they end up getting prolonged PT and INR because the most important factor here that gets depleted is factor VII, which has the shortest half-life, as I mentioned, of all the clotting factors of 3 or 4 hours. These patients do not present with dramatic bleeding or even clinically significant bleeding, but you should be able to identify a patient in the hospital who has an isolated prolonged prothrombin time and a normal PTT and think about whether or not they're getting adequate vitamin K. This is an important disease, going from clotting factors to platelets, ITP. What you're looking at right here are petechiae, little red dots in the skin. If you push down on these dots with a microscope slide, you'll see that they don't blanch, they don't change color. It's a permanent red color in the skin. It's bleeding into the skin. Here's another view of this. And this is what we call purpura. And patients who have this disease, this is what their smear looks like. If you look under the microscope, you'll see they have severe thrombocytopenia, but they have these giant, juicy platelets. And so ITP is an immunological disease where the immune system starts to attack platelets and they get cleared from circulation. And so these patients will have normal white blood cell counts and normal hemoglobin, and their platelets will be in the toilet. If you focus on this part down, the megakaryocytes in the bone marrow give off platelets, and B lymphocytes make antibodies to these platelets, and these are recognized by those same splenic macrophages that I showed you the other day when I was talking about autoimmune hemolytic anemia, and the macrophages recognize these opsonized platelets and engulf them. And so it's almost identical pathogenesis to autoimmune hemolytic anemia, to Coombs positive hemolysis. This is a relatively rare disease, but we see it a lot in the hospital, in our practices. Unfortunately, you've probably been exposed at this point to what we call a diagnosis of exclusion. There are certain entities in medicine where there's no diagnostic test. Someone has a heart attack, you can check a troponin. If you want to look for a blockage around the heart, you can do a cardiac catheterization. If you want to see if they have hepatitis, you can check a blood test for that. There's no blood test that tells you whether or not a patient has ITP. Because there are lots of you in this room who actually have antibodies to platelets in your circulation and don't have low platelets. And there are people with ITP where you can't find the antibody. So unfortunately, with ITP, you make the diagnosis by excluding all other causes of thrombocytopenia, which we don't expect you to do yet, but you should appreciate that it's a diagnosis of exclusion. It's found in other conditions because it's an autoimmune disease. We'll see it in autoimmune diseases like lupus. We'll see it in forms of leukemia and lymphoma. Just like autoimmune hemolytic anemia, the treatments can be quite similar. You can give steroids because steroids will dumb down the splenic macrophages and keep them from recognizing the opsonized platelets. And so, the platelets will remain in circulation for longer. And long-term steroids will cut down on the antibody production against platelets. You can give something called intravenous immunoglobulins, which is basically a cocktail of antibodies that have been collected from hundreds of donors. And you can give this intravenously to a patient, and it saturates all the antibody receptor sites on the splenic macrophages so that opsonized platelets are still in circulation, but the macrophages don't recognize them anymore because their receptors are occupied by antibodies looking for things other than platelets. I don't know if you'll learn more about this week. There's a red blood cell group called D. This is what makes you either your blood group positive or minus, if you're A positive or A negative. This is the D antigen on your red blood cells, and Dr. Hode will talk about this on Monday. You can actually give antibody to this to a patient, and what will happen is the patient, instead of attacking their own platelets, will start attacking their own red blood cells. And this is kind of like a decoy effect, where you have a patient with severe thrombocytopenia and they're bleeding, and you need to reverse it right away. If they have a normal hemoglobin, you can give them something like this, and it will stop the attack on their platelets. Now, you may say this is crazy because the splenic macrophages will start attacking the red blood cells and they can get severe hemolytic anemia. And you're right, but this only happens in a small majority of cases. Minority, sorry, thank you. If you remove the spleen, that can cure this. As I've mentioned for other things earlier this week, if you get rid of the B cells that make this antibody, you can get rid of the disease. And so rituximab, which is a monoclonal antibody to B cells, would be a good treatment for this disease. Back in the 1990s, we started making recombinant thrombopoietin, which I mentioned earlier is the hormone that drives platelet production. People said, oh, wouldn't this be a great idea to give this to patients with ITP? And what ended up happening is lots and lots of people who received recombinant thrombopoietin ended up developing antibodies to it. And so these patients were never able to make platelets on their own again. So what the drug companies then did 10 years later is they made thrombopoietin mimetics. These were concocted proteins that stimulate the thrombopoietin receptor on megakaryocytes to make more platelets, but it really had no homology to thrombopoietin. And so it could stimulate platelet production without a neutralizing antibody. And there are these two drugs that are available now. They're both more than $50,000 a year, but for some patients with ITP, they're a good alternative. These are common, more common than anything else I've talked to you about today. Again, in a few weeks, you may learn about something called kidneys. When the kidneys fail and you become uremic, your platelets don't function properly. Your endothelium doesn't function properly, and you can bleed. Sometimes dialysis can fix this, sometimes it doesn't. You can give patients who have severe bleeding because of renal failure, you can give them DDAVP, and that same surge of factor VIII and von Willebrand factor, which is useful for patients with von Willebrand's disease, can be useful in patients with uremic platelet dysfunction. Lots and lots, we poison platelets all the time on purpose. Aspirin can do it. These two medications are used in patients with coronary artery disease. Your ibuprofen and naproxen can do it. Binge drinking on the weekend can do it. And there are many medications that can cause thrombocytopenia. Some of them cause ITP, like penicillins, and some of them suppress the bone marrow. And the list is pages long, and I won't go into it, but you should be able to appreciate that there are medications that can cause both ITP and can also suppress platelet production in the bone marrow. This is a list of other things that we see in the hospital that can cause thrombocytopenia. Most of these are pretty rare, except for, sepsis is very, very common. But the things below sepsis are relatively uncommon. Appreciate that they can cause thrombocytopenia. When the spleen becomes enlarged, it's like a pool, and it can just soak up platelets in there. And so patients who have splenomegaly because of cirrhosis, because of an underlying hematologic malignancy, can have thrombocytopenia from that. These are rare. Again, it's like I told you the other day, that there are certain things before USMLE step 1 that you look at like an hour before the test. You strong arm it, you cram it, and then you forget it. These are those things. So, I've never seen gray platelet syndrome. I think I've seen one case of this. I keep diagnosing this. There's a pocket of Hermansky-Pudlak syndrome in northwest Puerto Rico, and so we see a fair amount of it around here. But these are very rare diseases, and I can't tell you that they won't show up on tests or on your tests, but the yields from, this is not stuff that most of you will ever see in practice very much. But you should certainly understanding, the functional characteristics of these two diseases is important and is something that you could be expected to be tested on. DIC, I'm running late, holy cow. I started late. All right, you guys got here late. I'll torture you. DIC this is very important. You all have to understand this. Just like this is low yield, this is high yield. You'll be tested on this. You'll probably be tested on this next week. You'll be tested on this on USMLE step 1 and step 2 and so forth. Here's the clotting cascade again, the extrinsic pathway, the intrinsic pathway. Imagine what would happen if there was a stimulus that made the clotting cascade go crazy. Imagine if you had a surge, say, of tissue factor, a huge surge of tissue factor that made the extrinsic pathway run wild and then made the intrinsic pathway go wild. What would happen? You'd eventually run out of clotting factors. So even though you're thrombosing like mad, eventually you run out of clotting factors and you could actually become at risk for bleeding because you've got nothing left to promote hemostasis. And so disseminated intravascular coagulation, I call it consumptive coagulopathy. You consume your clotting factors, and because of that, you're at risk for bleeding and clotting at the same time. It's a bad thing. There are things which can activate this process. And I'll go into that next slide. And once the process is initiated, you end up getting development of microthrombosis in the circulation. It causes platelet aggregation, it causes endothelial damage, your clotting factors get used up, your platelets get used up, and remember, when you clot, you make fibrin, and then you have fibrinolysis. Your body starts to break down fibrin clot, and so your D-dimer will go up. What does this? Infections can do this. Classically, meningococcemia can do this. If you give somebody a huge amount of blood, if someone's in a car accident and you give them, say, 15 units of blood, that blood doesn't have any clotting factors in it. It only has red blood cells in it. So the patient's bleeding, and you give them lots of red blood cells, and that dilutes out whatever clotting factors they have left, and that can cause a dilutional form of DIC that makes the bleeding worse. Different cancers can do this. Different snake bites and scorpion bites can do this. Traumatic brain injury can do this. The brain is very rich in tissue factor, and so patients with traumatic brain injury can be at risk for DIC. You have to know this slide. This will show up probably on more than one test in your career. Here, remember, you have thrombosis in the microcirculation. You have these microthrombi. So like TTP, they can have this thrombosis in the microcirculation, and that can cause red blood cells shear and schistocytes. You don't have to see schistocytes in order to have DIC. In general, the lower your fibrinogen is, the worse the DIC is. This is what it looks like. The classic presentation on a test is somebody who's oozing from all of their puncture sites. So they have a bunch of different catheters, and they're oozing from all the catheters, they're oozing from their nose, they're oozing from their endotracheal tube. And the same person can have bleeding, like you see here in the skin, and clotting, like the gangrene that you see here at the same time. Or they can have one predominantly over another. But again, for the reasons I explained, both can happen at the same time. DIC is a pathway. It's not a disease by itself. Something causes DIC. It doesn't happen spontaneously. So you always treat the underlying cause. If it's cancer, you treat the cancer. If it's an infection, you give antibiotics. If it's a brain injury, you support them through it if you can, or you treat the brain injury. If the fibrinogen goes below 100 and the patient's bleeding, you give them a blood product called cryoprecipitate that you'll learn about on Monday, which is rich in fibrinogen, and it will fix the bleeding. You will learn about heparin, which is a blood thinner, on Monday. And believe it or not, you can give a blood thinner to fix this process. Even though the patient's bleeding, you can give them a blood thinner, because heparin, if you remember, inactivates factor 5A and factor 8A, and so that will turn off the clotting cascade, or 2A and 10A, and so that will turn off the clotting cascade. And the whole basis of DIC is the clotting cascade running wild. So if you give a blood thinner that turns off the clotting cascade, you can turn off DIC. This is how you should organize all of the information that I've explained to you in this lecture. Again, you haven't learned about warfarin yet, but that's going to come up soon. Contact factor deficiency is not something you really need to know about, but understand that it's there. And again, you won't be tested on this. But all these other things are things that we've discussed. And this is how you can compartmentalize all of this information. My last slide is the same as my first slide. Remember, common things are common. If you hear hoof prints, it's not the Pegasus. All right, take a 5-minute break. Do you know Craig Kessler? Okay. Because a patient came to me yesterday and said, "Oh, Dr. Kessler recommended that I come see you because she was getting treated down." And I'm like, "How the heck would this guy know who I am?" Okay. Like, you know what? He probably just looked at the website. It's not that he. Though Alice trained with him, I think.
Okay.
I think that she did
That's
fellowship.
certainly possible.
He was at GW. He was at GW.
He was at GW for many, many years.
Yeah, I think he.
I think he recently retired.
Well, I still have his textbook.
Oh, it's textbook.
Yes. Sure. You're making clot, and the body will spontaneously start to break it down, and so that's when D-dimer goes up. Yep. So it's decreased because it's getting used up. So you have tons of fibrin deposition all over the body. So fibrinogen, which is an unused clotting product, is used up, but fibrin is all over the place. Yeah. Mm-hmm. Hey. Yes. The half-life of IgG is 3 weeks, and so to get rid of the IgG and your own antibody will take too long.
Oh, I see. So,
whereas with the IgM, the half-life is 5 days, so you can get rid of a lot of the antibody in 2 days.
but this is a very concentrated
It's a temporizing measure. You know, if you need to get a quick response, because turning off antibody production otherwise takes a little bit more time.
So I see. So your plasma base is not 100% efficient.
No, you'll never get rid of all of it. So hopefully just kind of bring it down enough that it will suppress the sequence.
And for fractional,
For a sentinel
Phoenix, so why do you think the thrombosis? Does it affect all?
We don't know why it causes thrombosis, but it does affect all the blood cells. So I would guess that there's something wrong with the platelets. It leads to thrombosis, but no one has shown what it is yet.
And blister cells?
The GCCD deficiency.
Yeah, what exactly are they the ones with like half is the other half is
So it looks like there's like a blood on it. Yeah.
Look, basically what happens is that we get precipitated hemoglobin that's in the cell gets the macrophage comes in and basically chews that out of the cell and leaves a hole.
Oh, so that's
It's a membrane that seals over.
But that's, I thought it was a white cell.
It's the same process, it's just a matter of how much.
So that's not.
sections, and some person might be born with like 50% Saccharine activity, and other person born with 150% Saccharine activity, and that might balance out the fact that people can be, better or worse. Okay.
You're done. Well, except for the ARS. That's right. You're doing the review session also.
That's all right.
All right, why don't we get started, guys? Yo. All right, why don't we get started here? Let me just. All right, why isn't this? Oh, here we go. Okay, we're gonna go to the opposite of the bleeding disorders that Dr. Eisenberger talked about. This lecture is going to be sort of in two parts. Today we're going to talk about a lot of the pathophysiology of how the clotting system is controlled, some of the disorders that happen when the system gets out of control, and Monday's lecture will be focused on a lot of the drugs that we use to basically turn off the clotting cascade. This will be an extension of the lecture I gave you guys in the cardiology section of the course, where we mostly focused on platelet blockade. This one will focus much more on blockage of the coagulation system. Some of these things you will have heard in various and sundry other lectures, but this really is a reinforcement of some of this. As I mentioned yesterday, a lot of hematology ultimately is circular. We have to break into the circle somewhere, and so hopefully this will start to tie together a lot of the stuff that we've been talking about. This is the usual disclosure stuff, and hopefully you will learn about all these things during the course of this lecture. So, one of the things to note, as Dr. Eisenberger has told you, is that coagulation is absolutely necessary to maintain vascular integrity, and probably the biggest indicator of that is that hemophiliacs in the pre-treatment era for hemophilia, I should say, started around 1960, so this is not a huge amount of time ago. Prior to the advent of treatment for hemophiliacs, the median survival for these boys was 10 years of age. They obviously didn't reproduce at that age, and so you lost about a third of the genes in the population every generation. Having said that, there's an enormous amount of redundancy in the clotting system. There's enough fibrinogen so that if you convert it all to fibrin at one time, you can essentially block all your blood vessels. That's not compatible with life either. And so what we're going to talk about today is what turns off the clotting process and what happens when those mechanisms get screwed up. So this is one of the many depictions of the clotting cascade. All of them are confusing. I apologize for that. There's not much I can do about that. The important things to note on this particular slide, though, is that the control of the clotting process is really carried out through the formation of two macromolecular complexes, the 10A complex, where factor 8A and factor 9A on the surface of a phospholipid serves to activate factor 10 to factor 10A, and then the prothrombinase complex, where the combination of factor 10A and 5A, also on a phospholipid surface, serves to convert prothrombin to thrombin. And in the rate of formation of these complexes is determined not by the enzymes, as it is with many enzyme systems, but by the levels of the cofactors, factor 8A and factor 5A. And if you decrease those cofactors to any significant extent, you can essentially slow down the clotting process to the point where it becomes physiologically non-relevant. Now, there are a host of inhibitory systems that are present within the body, and these are some of the things we'll talk about. The tissue factor pathway inhibitor is the most recently discovered of this. This particular protein complexes with the combination of 7A tissue factor and factor 10A and serves to inactivate factor 10A. That basically renders much of the extrinsic pathway null and void in terms of physiologic clotting. Most of the physiologic clotting that occurs via the activation of factor 9A by the tissue factor and 7A complex. There's no deficiency state of this particular protein that's ever been described. Part of that may be that deficiency state is a genetic lethal. Part of it may be that the assay for this protein is such a royal pain in the butt to do that nobody's been able to adapt it to screen populations. There have been deficiency states described of every other protein that's listed here, including antithrombin, heparin cofactor 2, protein C, protein S, thrombomodulin, and plasminogen. And we'll talk about these systems over the next several minutes. So we'll start with the antithrombin system, and antithrombin is the classic SERPIN inhibitor, serine protease inhibitor, and antithrombin actually binds to the clotting factor, the activated clotting factors, particularly thrombin and factor 10A, and serves to inactivate those essentially by pulling them out of the circulation. Now, that reaction under normal circumstances is a very slow one. It has a very high activation potential, and so it's not generally relevant. However, in the presence of heparin, heparin actually binds to both antithrombin and to thrombin and causes conformation changes in both molecules that greatly accelerates the combination of antithrombin and thrombin. And we take advantage of this when we use heparin as an anticoagulant to turn off the clotting process. Heparin is a classic chemical catalyst. Once that combination of thrombin and antithrombin occurs, the heparin floats off to inactivate another molecule. There are heparin-like molecules that are present on the surfaces of your endothelial cells, and it's part of what renders the endothelial surface an antithrombotic surface. So basically that complex serves to bind to and inactivate the enzymes of the clotting system to stop the clotting process when it's no longer needed. The second system we're going to talk about is the protein C, protein S, and thrombomodulin system, and Dr. Eisenberger talked a little bit about this in a couple of his lectures. But this system basically works by cleaving the cofactors, factor 5A and factor 8A, and inactivating them by rendering them unable to bind to their enzymes. Now, Dr. Eisenberger had mentioned in one of his lectures that thrombin not only serves as a procoagulant, in fact, the ultimate procoagulant protein, but under physiologic conditions, in the absence of thrombosis, thrombin actually is also the major anticoagulant protein. And thrombin, when it's bound to thrombomodulin, actually serves not to cleave fibrinogen to fibrin, but to activate protein C. Thrombomodulin is a transmembrane protein that's present on the surface of endothelial cells, and when thrombin binds to thrombomodulin, it loses its ability to cleave fibrin. It also loses its ability to activate factor V to 5A and 8 to 8A, and it also loses its ability to activate platelets. However, what it does do when it's bound to thrombomodulin is it greatly accelerates the conversion of protein C to its activated form. And protein C, when it's activated, then serves to cleave factors 5A and factor 8A to essentially destroy their ability to bind to to the enzymes. Protein S acts as a cofactor for activated protein C, accelerating that reaction by about 1,000-fold, so that under normal homeostatic conditions, thrombin actually acts not as a procoagulant protein, but as an anticoagulant protein, and it's part of what keeps your blood from clotting under normal circumstances. And finally, plasminogen is a zymogen that's present in our circulation. It's converted to plasmin, and plasminogen is a general protease. It will basically eat anything that comes into its path, but it has a particular affinity for fibrin and to a lesser extent factor VIII, and so it basically breaks fibrin and also fibrinogen into smaller pieces, serving to take the fibrin clot, which is basically insoluble in water solutions, and break it into pieces that are in fact soluble. One of those pieces is a D-dimer that Dr. Eisenberger told you about, is one of the things we measure to look at the activity of plasmin under normal circumstances. So that the process of fibrinolysis basically breaks down clot when it's no longer needed, and serves to recanalize blood vessels that have been injured, whose injury has now been repaired. So, Dr. Eisenberger mentioned that bleeding disorders are generally either X-linked recessive or autosomal recessive disorders. In other words, you need two abnormal genes in order to drop your levels of those proteins to the point where it becomes physiologically relevant. That's not true of most of the anticoagulant proteins. Typically, for the anticoagulant proteins, if you are missing one of the two genes you normally have, you see an increased incidence of venous thrombosis. You see occasional increases in arterial thrombosis. If you are unlucky enough to be born with two abnormal genes, generally you don't survive, first of all. There's a condition known as neonatal purpura fulminans, which is seen in people who are homozygous for protein C, protein S, or antithrombin 3 deficiency, in which these babies develop massive thrombosis, disseminated intravascular coagulation, usually within the first week of life, and most of these children die during the first week of life. Those who do survive will have chronic fibrinogenolysis and chronic disseminated intravascular coagulation, and we'll talk more about that later. Now, there have been a couple of different phenotypes that have been described in patients who have deficiencies of the anticoagulant proteins. There's a so-called dominant phenotype, which we were just talking about, where you see thrombosis at a young age, an increased incidence of venous thrombosis, and thrombosis without predisposing factors. In other words, without injury, without immobilization, without surgery. If you do sensitive assays to look at thrombin generation, you can demonstrate increased thrombin generation. And most of these patients have a positive family history for thrombosis in an autosomal dominant pattern. So in other words, every generation you see a positive family history for thromboembolic disease. And most of us, certainly through the late 1980s, early 1990s, felt that that was the only phenotype that was dealt with. And then Yuri Seligson described a family in Israel that had no family history on either side of thrombosis. They had the parents, neither parent had any personal history of thrombosis, but they had 2 children in a row who had neonatal purpura fulminans, and ultimately those children were discovered to have homozygous protein C deficiency. In other words, they had no protein C whatsoever. When they looked at the parents, both those parents and subsequent other families that had the same pattern, they all showed increased thrombin generation to the same levels that you saw for the people who were in this dominant phenotype. And in fact, when you looked at the mutation, we developed the ability to look at the genetic mutations actually crossed between the 2 phenotypes. So it wasn't simply that one family had a worse set of mutations than the other. Everybody scratched their heads about this for a long time, and finally Bjorn Dahlbach described the phenomenon of activated protein C resistance. Bjorn Dahlbach is a Swedish investigator. He had access to lots of specimens of people who had clotting problems, and he also had access to recombinant activated protein C. And one of the things he did, it was mainly a fishing expedition, was to toss activated protein C into plasma from a bunch of these patients who had clotting disorders. And what he found was about 40% of them, activated protein C failed to prolong the clotting times that were being measured. And nobody quite figured out what this was. They did some purification processes and found that it co-migrated with factor V from these patients, but nobody really knew what the defect was until Roger Bertina described a mutation in the factor V molecule, a single point mutation that caused the change of arginine 506 to glutamine. That happens to be one of the cleavage sites of activated protein C, cleaving factor V to its inactive molecule. And because the person that had this was from Leiden, this was named factor V Leiden. It has now been found in over 98% of patients who have activated protein C resistance. And what was also noted was that the people who had the dominant phenotype for protein C or protein S deficiency also, in at least 50% of cases, carried this mutation. And so what they found was that these mutations were in fact synergistic. This is actually one of the most common genetic defects that we see. It is a Northern European mutation. It clearly occurred after the migration out of Africa. About 5% of people of Northern European background carry this particular mutation, and if you look Europe, USA, Canada, all of those are about the same. India also has about 4%. Indonesia, and Australia, and New Zealand about the same. You do not see it in South American Indians. You don't see it in Africa. You have virtually none of it in China or Japan. And you don't see it in Aboriginal Australians. And this mutation clearly has a founder effect, and it has been preserved over the years, partly because it doesn't cause problems until most people have gone through their childbearing years, and partly because, at least postulated, that because these patients bleed less, and because we spend entirely too much of our time hitting each other over the head, that people who carried this mutation, in fact, had less risk of injury, less risk of intracranial bleeding, and so they survived longer, they had more children, and the gene has remained in the population as a result of that. Hopefully we're a little more civilized than that now, though sometimes I wonder, and so it's doesn't carry the protective effects that it once did. What it does do is that it increases the risk of venous thromboembolism about 4-fold in people who carry one abnormal gene, and about 10 to 20-fold in patients who have 2 abnormal genes. And as I mentioned before, it can exist in combination with defects in protein C, protein S, antithrombin 3, or plasminogen, and in combination it has a synergistic effect on the anticoagulant properties of those on the other anticoagulant protein deficiencies, so that it can basically convert the recessive phenotype to the dominant phenotype. This is just a picture from the book that wasn't recommended, in which people with factor V Leiden mutation lack this cleavage site for protein C's cleavage of factor V. This molecule is cleaved only more slowly than the average factor V molecule, so that as a result of that, you have increased prothrombinase complex formation and increased thrombin generation that then leads to an increase in the prothrombotic effects. In addition, let me back up here. In addition, it turns out that the native factor V molecule actually is also a cofactor in turning in the cleavage of factor VIIA by activated protein C. The factor V Leiden molecule lacks that ability, and so not only do you get more prothrombinase complex, but you also get more tenase complex because of the failure to cleave factor VIIA to its inactive form. There's a second mutation also found mostly in Northern Europeans that's been described, a mutation in the non-coding sequence of the prothrombin gene. It was originally described by Port in 1996. It's found in about 1 to 3% of people of Northern European descent. You see an increased synthesis of prothrombin in these patients. The primary risk in this particular mutation is in pregnancy-associated thrombosis and an increased risk of venous thromboembolic disease. We don't really know how this mutation causes an increased risk of thrombosis, but it clearly does. And it's also can be synergistic with some of the other, some of the more potent prothrombotic disorders. All right, so that's all I'm going to say about genetic prothrombotic disorders. There are a host of hypercoagulable disorders that exist in combination with other clinical conditions, and we're going to talk about the ones on this side of the list. These are other causes of prothrombotic disorders. We could probably extend this list by about 50 other causes, but we're not going to discuss those today. We'll start with inflammatory diseases, and it's been recognized for probably 100 years that people with chronic inflammatory diseases have an increased risk of thrombosis. And it was not at all clear why that was, but it turns out that there's a couple of things in chronic inflammation that occur that lead to an increased risk of thrombosis. One of them is you see an increased levels of C4b binding protein. C4b binding protein is a complement regulatory protein. It basically turns off complement. Complement levels, as you might imagine, go up in patients with chronic inflammation, and this is a compensatory mechanism for that to deal with that increased level of complement. However, C4b binding protein also binds to protein S, and when it's bound to protein S, the protein S is inactive as a cofactor in terms of turning off in terms of turning off factor 5A and 8A, so that you have increased levels of prothrombinase and tenase activity because of the failure to inactivate those complexes. In addition, people who have chronic inflammatory illnesses will also have increased levels of interleukin-1 and tumor necrosis factor, and both of these cytokines downregulate thrombomodulin by a couple of different mechanisms. They actually cause thrombomodulin to be endocytosed, so it basically comes off of the surface of endothelial cells. And in addition, it acts at the nuclear level to decrease the synthesis of thrombomodulin, so that by downregulating thrombomodulin and taking it off of the endothelial cell surface, you limit the amount of thrombin that can act as an anticoagulant protein. Thrombin is generated chronically all the time, and those low levels of thrombin that normally function as an anticoagulant now actually become more of a procoagulant protein. And that's thought to be at least part of the mechanism by which chronic inflammatory diseases lead to increased risk of thrombosis. A particular problem in terms of increased risk of thrombosis occurs when you have syndromes that cause you to lose proteins, and nephrotic syndrome is probably the most common one. We also see it with protein-losing enteropathies. Have you guys had GI yet? No. All right, both systems were out. Well, the intestines are different from the kidneys. At least hopefully they're not connected, unless some surgeon does it. There actually are operations where they actually connect the kidneys to a small piece of intestine. They're usually used in people with bladder cancer, but that's a topic for another discussion. Patients with nephrotic syndrome or patients with protein-losing enteropathy lose the ability to reabsorb protein from either their urine or their GI tract, and that basically leads to excretion of large amounts of protein in either the urine or the stool. You don't usually get both at the same time. And part of that problem, you excrete proteins that are similar in size to albumin, which is your major component of the major protein that's present in your circulation. Albumin has a molecular weight of about 67,000. Similar, your anticoagulant proteins, protein S, antithrombin 3, and protein C, all have similar molecular weights, and so you wind up either peeing out or pooping out those proteins in addition to the albumin that you can't reabsorb from these organs. And that then leaves you with low levels of these proteins and failure to turn off which limits your ability to turn off the clotting process. In addition, it turns out C4b binding protein levels tend to go up markedly in these syndromes, and part of that is because the body tends to make large amounts of large proteins when people have these syndromes as a way to try to maintain volume. Basically, the larger proteins will stay in the circulation and they suck fluid back into the body. The C4b binding protein has a very high molecular weight, so it's not typically filtered by the kidneys, even in patients with nephrotic syndrome. And so this level will go up, and any protein S that's left in the circulation will get stuck to C4b binding protein and will serve to inactivate protein S as a cofactor. Patients with these syndromes tend to have markedly elevated rates of thromboembolic disease. As many as 50 to 70% of patients who have nephrotic syndrome or who have protein-losing enteropathies will present at some point during their course with either a venous or an arterial thrombus. Now, the antiphospholipid antibody syndrome or lupus anticoagulant syndrome, this is one of the many terribly named things in medicine. And parts of the reason why it's terribly named, number one, it's not, while it was described originally in patients who have lupus, it's not necessarily associated with lupus. In fact, most of the times it's not associated with lupus. It's also not an anticoagulant, even though it may appear that way in some of the testing. It's actually a procoagulant. These patients have thrombosis, both arterial and venous thrombosis. They will frequently have false positive RPRs. RPR is a test for syphilis. It actually doesn't look at anything in syphilis. It measures antiphospholipid antibodies. It's also associated with recurrent spontaneous abortions. What causes the thrombosis in these syndromes is not at all clear, at least to me. There are as many opinions about this as there are investigators in the field. And I personally think it's probably secondary to vascular damage from an autoimmune disorder, but I don't have any more data than anyone else does as far as what causes the thrombosis in these patients. What is very clear, though, is that these patients are significantly prothrombotic. To diagnose this syndrome, we will measure antiphospholipid antibodies. This is usually an antigenic assay. It's not a functional assay. It doesn't tell you anything about why these patients have thrombosis. It's not even clear that the true antigen that you're measuring with these assays is really an antiphospholipid antibody, or if the antibody is actually directed against proteins that co-migrate with these. It's also not clear what the pathogenicity of these assays is measuring, and the assays have been impossible to standardize, even from batch to batch of reagents, so that it's very difficult to actually make a definitive call about what's causing the thrombotic risk in these patients. There's also a lupus anticoagulant assay, and this is basically caused by antiphospholipid antibodies that interfere with the clotting process in the test tube, but not in patients. We'll talk about this when we do the audience response system, but basically when we do prothrombin times or APTT assays, we do them on platelet-poor plasma, and we add synthetic phospholipid to the reaction mixture so that we actually speed up the reactions. Those synthetic phospholipids can be targets for these antiphospholipid antibodies, and the reason why this was basically called an anticoagulant assay in the first place is because, in fact, they cause a prolongation of either the APTT or less often the prothrombin time when you do these assays in the test tube, despite the fact that they actually cause clotting problems in people. Basically, to do this assay, you dilute the amount of phospholipids so that that level becomes the rate-limiting step, and you basically sensitize them to these antibodies. And you can also do a confirmatory study using platelets as a source of phospholipid or orthogonal phospholipids. All right. Dr. Eisenberger talked a little bit about TTP, but this is an important enough disorder that I'm going to go over this again. TTP is important as a disease entity, even though it's a relatively rare disease entity, because this is a disease that, without appropriate treatment, is virtually 100% fatal. With appropriate treatment, there's a greater than 90% survival, and most of the people that survive do not have any sequelae from the disease. There's a sporadic and a relapsing form. The relapsing form is sometimes congenital, but I'm not going to talk much more about that. You can see a congenital defect in which people lack the ADAMTS13 protein, or more commonly you see an antibody that develops against that protein and that then removes this von Willebrand factor cleaving metalloproteinase from the circulation, and that then leads to the cascade of things that Dr. Eisenberger described the other day. These are the findings that you typically see. I don't do mnemonics because I can't remember them myself. So, but basically, it's microangiopathic hemolytic anemia, and this is making this diagnosis really depends on looking at blood smears. The only people that look at blood smears these days are really hematologists and pathologists, and even pathologists are not very good at it sometimes. Don't tell them that, though they do manage to mess it up occasionally. And what you see on the blood smear are schistocytes, and Dr. Eisenberger showed you pictures of those earlier. And thrombocytopenia is also essential to making this diagnosis. You can see mental status changes, fever, and renal insufficiency as the patients have proceed down the course of their illness. The important thing is that you don't see coagulation abnormalities with this disorder, except in the very end stages of it. And this is again from our infamous textbook. Typically in patients will secrete von Willebrand factor multimers into the circulation, and this ADAMTS13 protein cleaves those multimers into smaller pieces. When patients have an antibody to this protease, it basically prevents that cleavage from occurring, and the high molecular weight multimers can lead to spontaneous platelet aggregation. Those platelet aggregates then partially block blood vessels, and red cells get sheared as they pass through the blood vessels. And this is just a picture of a blood vessel, what's known as a hyaline thrombus. It's present within the blood vessel. You can see a little bit of a lumen over here, and as these cells pass through these partially blocked blood vessels, they get ripped apart, leading to the finding of schistocytes that you see on this particular blood smear. This is a nucleated red cell that's basically caused by severe anemia. The treatment of this disorder, this is one of the few things where high-tech treatment has really made an enormous difference in terms of survival. Typically, it's plasma exchange, plasmapheresis of plasma exchange. It replaces the missing metalloproteinase, and it also removes the antibody to the metalloproteinase. Steroids are part of the treatment of this disease, and then rituximab and Christine splenectomy are oftentimes used for refractory cases. This needs to be an aggressive treatment, and it does need to occur. Sometimes goes on for weeks, but if you do it properly, as I said, the survival is greater than 90% if you recognize the disease and get people started on therapy. So you really do want to push to get this started even before some of the diagnostic tests come back. Okay. Heparin-induced thrombocytopenia. Heparin, as you know, is an anticoagulant. We'll talk a lot more about this on Monday. But heparin has a particular issue in that it is heparin is purified. At least most heparin that we give now is purified from porcine intestines, and because it comes from a different species, it is immunogenic, and it can lead to the formation of an antibody that binds to the complex of heparin and platelet factor 4. Platelet factor 4 is a protein that's present in platelets that actually binds to heparin. It's thought to be when platelets aggregate at a site of vessel injury, platelet factor 4 is released. It binds to the vessels, to the heparin-like molecules on the surface of the endothelial cells, and it actually prevents that heparin from interfering with the clotting process. But that complex can also lead to immunoglobulin formation, and that immunoglobulin formation then can cause problems with thrombocytopenia. Typically, you'll see a modest decrease in the platelet count, and the important thing is the timing, that it typically occurs 5 to 14 days after you initiate heparin therapy. You can certainly see thrombotic complications, although you don't have to see them with this disorder. This is probably the most common cause of thrombocytopenia in hospitalized patients, and part of that is because we give enormous amounts of heparin. As it says here, over 1 trillion units of heparin are given in any year here in the U.S. 1 to 3% of patients will develop heparin-induced thrombocytopenia, and 50% of those patients are at risk for developing life or limb-threatening thrombotic complications. You basically must stop the heparin at that point and consider the use of alternative anticoagulants. And again, we'll talk more about this on Monday. You can see this with exposure to any kind of heparin. High dose, though, is worse than low dose. Longer-term exposure is worse than shorter-term exposure, and IV is worse than subcutaneous exposure. You see it more commonly in cardiac or orthopedic patients or patients in intensive care units. Not entirely clear why that is, at least not clear to me. So this is actually an anticoagulant-induced thrombosis, and one of the most important things to remember, thrombocytopenia, as Dr. Eisenberger told you earlier, typically is a bleeding disorder. This is the exception to that. Heparin-induced thrombocytopenia is a thrombotic disorder. These patients do not bleed, and in fact, giving platelets to these patients can actually increase their risk of thrombosis, so you generally don't want to do that. You don't want to just stop the heparin, and you don't want to give warfarin alone. And again, we'll talk more about this on Monday. This is a depiction of the pathophysiology that happens. Basically, platelet factor 4 is present within platelet granules. When platelets are activated, the contents of those granules are released, and platelet factor 4 binds to heparin. That forms a neoantigen, which leads to the formation of antibodies, and those antibodies have the ability to bind back to the surface of the platelet. Surface of platelets have Fc receptors on them, unlike red cells that we talked about the other day that don't have Fc receptors. Platelets do, and when these antibodies bind to the surface of platelets, they actually will activate platelets, leading to the production of platelet microparticles. These microparticles are extremely prothrombotic, and that's what's thought to trigger the clotting issues that you see with this particular disorder. This is just a schema that we use for determining whether somebody has heparin-induced thrombocytopenia. We basically score these as 0, 1, or 2 based on when the thrombocytopenia occurs related to heparin exposure, the degree of thrombocytopenia, whether there is thrombosis present, and whether there are other causes of thrombocytopenia that's present. The maximum score is 8. Almost nobody has a net score of 8. If you're considering them with thrombocytopenia, virtually nobody has a score of 0 either. Low probability is 0 to 3. These patients basically don't need anything other than to stop doctors from bothering them. But people with intermediate or high probability need to be treated to prevent the thrombotic complications. Okay, disseminated intravascular coagulation. This is one of the more important coagulation disorders, and this is what happens when the clotting system really gets activated to an extent that you can't shut it off. It's typically divided into acute, and some of the causes of acute DIC are listed there, versus subacute. Most of these are either vascular abnormalities or cancers that lead to subacute DIC. The difference between these two is that acute DIC is typically associated with bleeding problems from the consumptive coagulopathy that Dr. Eisenberger mentioned earlier, whereas subacute or chronic DIC is much more commonly associated with thrombotic problems because you don't get as much fibrinolysis activated in patients who are in this setting. This is one of the very few conditions that you will see where you can see both hemorrhage and thrombosis at the same time. Most people that you see will either bleed or clot, but you don't typically see both of them at the same time. This is the exception to that. Some of these can cause massive bleeding problems, including and especially obstetrical problems or mismatched transfusions. This is thought to be at least some of the etiology for why, for how fibrinolysis gets activated in these patients. When you get clot formation, you also turn on the fibrinolytic process, leading to the activation of plasminogen to plasmin, and plasmin then serves to break fibrin apart. If this gets overactivated, then you will see predominantly the consumptive coagulopathy that you see with acute DIC, and you'll see much more in terms of generation of fibrin degradation products. You saw this earlier from Dr. Eisenberger. You see microthrombi that form within the vessels, and with that you get shearing of red cells as they pass through these partially blocked blood vessels. You see consumption of platelets in the microthrombi, and you see increased levels of fibrinolysis and concomitant decrease in clotting factors. You saw this picture earlier also, but commonly you see hemorrhage in acute DIC, but you can also see thrombosis leading to peripheral gangrene. This is a different depiction of the same thing that he told you, but basically the testing for acute DIC, there is no single test that will tell you that somebody has acute DIC. It is really a combination of the various tests that you normally use. Typically, the prothrombin time and the APTT will be prolonged. The fibrinogen level is usually low. We don't do thrombin times very often, but they're usually very prolonged. The factor levels vary depending on the degree of DIC that's occurring. The platelet count will usually be low. Red cell fragments or schistocytes are sometimes present, but they don't have to be, and fibrin degradation products are usually present. If you have all of these, the diagnosis is usually fairly easy, but you can have any combination that you see there. Okay, what do you do here? It really depends on what the primary manifestation is. People who are thrombosing primarily need to get anticoagulants. People who are bleeding need replacement therapy, and they may also need anticoagulants. But the primary treatment in DIC, if you remember nothing else about this, remember this: the primary treatment in DIC is to treat the underlying disease. DIC is a syndrome. It is not a disease in and of itself. Something triggers it. And if you can treat the underlying disease, you need to treat the underlying disease, whether that's infection, whether it's cancer, whether it's trauma, whether it's retained products of conception, such as you see in obstetrical disasters. You need to treat the underlying disease. You also need to replace the products if they are low. Cryoprecipitate is typically used to replace fibrinogen. Fresh frozen plasma is used for other factors, platelets if they're low. Heparin is rarely indicated, but there are times when you should give heparin. I will caution you not to do this except with a hematologist that's on board, because you are giving a blood thinner to somebody who is bleeding, and that's oftentimes very tricky. All right, so I'll stop there and take any questions you have. clear as mud. Okay, hey, how are you? Okay, so the first part of this, we're going to do the audience response, and then I have a bunch of things I want to go over with them. I couldn't really figure out how to do questions on it, so.
Okay. So I went through your slides. I just wanted to take a quick look at them this morning, and they all look
Okay.
correct.
Right.
So
Yeah, I had the one yesterday that I didn't even realize I must have inadvertently removed the graph.
Yeah.
So that when I went to do the polling, it wasn't there.
So before we do anything else, let's do a reset. So this is where sometimes I've been experiencing there's been a little bit of trouble, but on the Windows side it usually is fine. On the Mac side it's been having a little bit of problems. So this way when we've got a couple of minutes, we can do it now and get it out of the way.
Yes.
Okay, so that looks like that's done. Yep.
I actually tried this last time when I was making these, and it actually worked perfectly. So,
Yep.
okay, that seems to be.
Great. I was able to get in just fine.
Right.
Let's try something really quickly. Is there a way to?
Blank the display.
Yeah. The button that says blank display. Go figure.
Only because we did it yesterday.
And let's go ahead and give it a try. So if we go ahead and start the PowerPoint. So I'm logged in. Let's see. Good. Okay, so polling opens and everything. I'm not going to actually respond so that you actually get clean data, but that's what I wanted to check.
Okay.
So that should be. I think we're all set.
Okay. Great.
And I might sneak out when you're done with ARS because as I saw,
That's
and
fine.
you said you stop halfway through.
Yeah. No, that's fine.
Perfect.
Thank you.
Yeah, thank you.
Yeah.
Okay,
Just
because
for-
I'm looking at the echo. I'm like, I don't see anything. I'm like, there's no.
Oh, yeah.
There's nobody. Okay.
Yeah, no, I just have it blank right now. But
All right. Don't forget to unmute the.
yeah.
Okay. I'm like, I'm not seeing this.
All right. All right. All right. Why don't we get started here? So, the first part of this is going to be, well, will be an audience response session, and then I want to spend a little time talking about coagulation testing, how it's done, what the pitfalls are, just because it's one of those areas that is more than a little arcane, but I think it is something that if you understand how the tests are done, a lot of the problems that you get interpreting the tests will become much clearer. So, but before we do that, questions on anything that you've heard so far? It could be from anywhere in the course. No, maybe. I don't bite. At least I only bite my brothers and sisters, and they richly deserve it. Okay. So the first case today is a 62-year-old male mechanic who complained of weakness and lightheadedness of 5 weeks duration. 1 year ago, he had to give up his weekly bowling game because of fatigue. 5 weeks prior to admission, he had to go onto a half-time schedule at work, also because of fatigue. He's also noted unsteadiness of gait, especially in the evening, along with numbness and tingling in his hands and feet and burning of his tongue. In the past 5 weeks, he's had a poor appetite and has lost 12 pounds. There are many of us who would love to lose 12 pounds in 5 weeks, but we won't go there. His exam was remarkable for an atrophic tongue and 1+ pedal edema. His neurologic exam, he had impaired vibration and position sense, an ataxic gait, a positive Romberg test. A Romberg test is basically done, I'm not climbing up on the table. You have a person put his heels together, hands out to the side, and close their eyes like this. And they should be able to hold this position for at least 20 to 30 seconds without toppling over. I will, if somebody is significant, you should do this with a person in front of a table, so if they lean backwards, they don't fall on their derriere. And if they're significantly larger than you, then you probably need to at least brace yourself so that if they come forward, that you can actually hold them up, because people do fall sometimes when you do this test. But it's an important marker for whether there's impaired neurologic function, particularly impaired cerebellar function. He also had issues of impaired recent memory, which actually his wife had noted more than he had. Oops, that isn't what I wanted to do. Okay, his blood counts are listed there. You can write these down because I'm not going to be able to switch back and forth. But basically, he had a mildly low white count, a mildly low platelet count, a moderately to markedly low hemoglobin level, an elevated mean corpuscular volume, a low reticulocyte count, even a low absolute reticulocyte count, not even adjusted for his degree of anemia, and he had a markedly elevated LDH, lactate dehydrogenase level. I keep forgetting to spell that out. Okay, so first question, which of the following can cause a macrocytic anemia? You can discuss any of these amongst yourselves as you see fit. All right, we're going to do 15 seconds more. Okay. All right. All right. Well, I don't think we have to discuss anything then. That may be a first. Thalassemia minor typically causes a microcytic anemia. You can actually see a very mild macrocytosis with sickle cell anemia, although most commonly they're normocytic, just because they do hemolyze and they usually have a high reticulocyte count. Hypothyroidism leads to macrocytic anemia. And I'll tell you a story about that. My wife, back when she was my girlfriend, went to give blood one day and she got rejected as a blood donor because her hemoglobin was too low. And being the good hematology nurse that she was, she didn't believe anything that they said, so she went back to the lab and had them draw a CBC on her, and she had a hemoglobin of like 9.5 and an MCV of like 102 or something of that sort. And then the head tech, who was her best friend, handed a bunch of us, including me, the slide to look at, and we all took a look at it, and they said it looks like maybe a mild, it may be an early myelodysplastic syndrome, which you don't need to know about for this, but it's a primary bone marrow disorder. And then she told us who it was, and then I think it wasn't me, one of the other fellows that looked at it. Said we probably should check thyroid function tests just to be sure. She had a T4, which is the major thyroid hormone, that was below the detectable limits of the lab, and the highest level of anti-thyroid antibodies that had ever been recorded, and still has ever been recorded in the laboratory at Tufts. And she had Hashimoto's thyroiditis, and she didn't think anything of it because she was working full-time and going to school full-time and sleeping about 4 hours a night and having a fairly active social life, of which I was only a small part. And she just thought she was tired because she was tired and hadn't been getting enough sleep. And putting her on thyroid medicine made her into a completely different person. Of course, in the week between the time they drew the blood tests and the time that we got all the results back, she actually developed myxedema madness, and she was completely crazy at the time. All right, enough of that. What's the most likely diagnosis for this guy's anemia? After the last one, I'm going to expect $15 seconds. 5, 4, 3, 2, 1. Okay. Well, the overwhelming majority of you got this one right. This is B12 deficiency, and the reason why it's B12 as opposed to folate deficiency is because of the neurologic signs and symptoms. In terms of the impaired position sense, impaired vibration sense, which are due to posterior column problems, and numbness and tingling are due to lateral column problems, and you don't see those with folic acid deficiency, with folate deficiency. One thing I will caution you about, though, most folate deficiency that we see is still in alcoholics, and alcoholism actually can lead to a peripheral neuropathy as well, which you see much more in terms of lateral column problems as opposed to posterior column problems, but you can mimic a lot of the neurologic findings in people who are alcoholics, and so you just need to be a little cautious about that. But the neurologic signs and symptoms make this much more likely to be vitamin B12 deficiency, which is in fact what he had. Now, so what else was I going to say about this? Okay, let's go to the next one. Okay, all of the following tests are likely to be abnormal except. So which one is likely to be normal based on this? All right. 15 seconds. Five, four, three, two, one. Okay. Most of you got the right answer here, which is folic acid. B12 levels, as we said before, this is a person with B12 deficiency. B12 levels are going to be low. Homocysteine is the homocysteine and methylmalonic acid levels highlight two of the reactions that vitamin B12 carries out. In the demethylation of tetrahydrofolate, that methyl group is actually donated to homocysteine to form methionine. And so if that reaction can't occur, you get a buildup of homocysteine. And so typically the homocysteine levels will be elevated in that. Homocysteine levels will be elevated in both folate and B12 deficiency because basically folate levels are, because folic acid is also required for that particular reaction to occur. Methylmalonic acid levels will be elevated because the conversion of methylmalonic acid of methylmalonyl-CoA to succinyl-CoA is a B12 requiring reaction. It's a reaction in the Krebs cycle. The succinyl-CoA is then broken down into a variety of different compounds, eventually carbon dioxide and water, but the conversion of methylmalonyl-CoA to succinyl-CoA requires vitamin B12. If you're lacking B12, methylmalonic acid levels will be elevated. Again, one caveat on both of those tests: if somebody has kidney dysfunction, both homocysteine and methylmalonic acid levels will be elevated just because of the kidney dysfunction. So you can't rely on those as a marker for megaloblastic anemias in patients who have concomitant kidney dysfunction. Okay. Yes.
Will methylmalonic acid be elevated with folate deficiency as well?
No, because that reaction only requires B12. It does not require folic acid. Yes. The question was, that B12 is required to absorb folic acid, and actually it's not required to absorb folic acid, it's required to trap folic acid within the cell. But folic acid actually diffuses, at least a transport form of folic acid, actually freely diffuses across cell membranes, both in the GI tract and in the rest of the body, so that there's not an active transport mechanism that carries folic acid into cells. Okay. Which of the following can account for his markedly elevated lactate dehydrogenase levels? Right. And remember, we're talking about this patient now. We're not talking about all comers. Okay. 10 seconds. Okay. All right. Well, this one we do have a problem with then. Because ineffective erythropoiesis is the hallmark of megaloblastic anemias. Basically, basically what happens is that these patients make lots and lots of red cell precursors. Remember the bone marrow slide that I showed you? The bone marrow was literally chock full of red cell precursors, but those red cell precursors can't mature, and they eventually get destroyed in the bone marrow. You also see ineffective erythropoiesis in a number of myelodysplastic disorders, but not to this extent. And you also see it in thalassemia major, which can also cause these markedly elevated LDH levels, lactate dehydrogenase levels. Non-Hodgkin's lymphomas can give you high lactate dehydrogenase levels, but there's no indication that this person has a non-Hodgkin's lymphoma. And usually the levels are higher in megaloblastic anemias than they are in other disorders. And intramedullary destruction of red cell precursors basically is also that's part of the definition of ineffective erythropoiesis, is that the cells are being destroyed before they get out of the bone marrow. So the actual answer to this one is really B. You can't even see that. Sorry about that. But the answer to this one is really B, because these other two are really what you typically see in patients who have megaloblastic anemia. Okay. What's the cause of his? Yes, sorry. Red cell precursors have large amounts of lactate red cells in general, precursors and mature red cells have large amounts of lactate dehydrogenase in them. And the reason for that is because even though red cells carry lots of oxygen, that's their raison d'etre, their own metabolism is actually anaerobic. Because they lack mitochondria, they can't obtain energy for their own survival via the Krebs cycle. And if you remember, the end product of glycolysis is lactate. Lactate is extraordinarily toxic to cells, and so any organism or any cells that exist primarily on glycolysis as their method of energy production will also have high levels of lactate dehydrogenase to basically remove the lactate and detoxify it. So, okay, what's the cause of his neurologic symptoms? 10 seconds. Okay. Okay, good. Basically, the neurologic symptoms in B12 deficiency are thought to be due to the fact that vitamin B12 is necessary for myelin production in the central nervous system. The exact enzyme that carries that out is not known. People have been looking for it for decades, and they haven't been able to find out exactly what protein it is. But what is very clear is that that you don't produce myelin normally, and therefore you don't, the nerve cells don't get the usual myelin sheath on them, and that causes them to not be able to transmit signals properly. Basically, what we think happens is that myelin basically shields the nerves against the loss of the signal as it gets propagated down the axon, and so if they don't get myelinated properly, the signals basically deteriorate as they pass down the nerve, and so they don't get to where it is that they need to go. Or if they do get there, they get there in a deranged fashion, which then leads to a lot of the symptomatology that you see from neurologic damage. Myelin gets, nerve fibers get myelinated in, it's a very slow process. It's usually a couple of centimeters a week, and when things are working normally. So even when you replace the vitamin B12, it oftentimes takes months to years for those nerve sheaths to totally regenerate, and so the neurologic damage that you see with vitamin B12 deficiency, unlike the hematologic issues, the neurologic damage actually takes a very long time to resolve, and sometimes doesn't resolve at all. I told you about my roommate from medical school who, he actually has recovered full neurologic function. He was crazy before, but and he still is, but he actually recovered all of his neurologic function, except he still has a little numbness in his fingers. Okay. Yeah.
I remember yesterday you talked about combined systems. Can you check to that?
Mm-hmm.
Is the combined systems disease what we call this phenomenon, or is it a separate thing?
Now, combined systems disease is actually, the question was, how does this relate to the term combined systems disease? And combined systems disease is actually the name that's been given to the neurologic dysfunction that you see with B12 deficiency. And it's called that because you see both peripheral nerve dysfunction that leads to a lot of the problems that you see in terms of walking and numbness and tingling and so forth. And it also causes central nervous system dysfunction, which leads to the dementia and the psychosis that you see with this disorder. One other thing, just as a clinical point, it is very common for patients who have significant B12 deficiency to have many more problems at night than during the day. And the reason for that is during the day, they can use visual cues to basically know where they're putting their feet, and so they don't have the problems of tripping over things or falling that you see during the daytime, but at night when it's dark, they don't have those cues. They also tend to walk sort of like a duck because they tend to have a very wide-based gait because they get more stimulation going from here up if they sort of slap their feet on the ground in order to increase the amount of stimulation so that they know where they are. All right, so I figured I would take some time to talk about the clotting tests that we do on a regular basis, particularly the prothrombin time and the APTT values, because this is something that people don't always understand, and it's important to know in terms of how to interpret the tests. And these are the clotting studies that are done are classic recalcification times. In other words, calcium is, and we probably didn't emphasize that enough, calcium is necessary for clot formation to occur. All of the reactions that we talked about leading to the production of a blood clot, or almost all of them, are calcium dependent except for the conversion of fibrinogen to fibrin. The vitamin K dependent proteins are vitamin K dependent because the vitamin K dependent carboxylase adds a carboxyl group to those proteins. Actually, that adds 7 to 10 carboxyl groups to those proteins that gives them the ability to bind to calcium ions. So if you take away all the calcium ions, basically you don't get clot formation. You also don't get cardiac function because calcium is necessary to stimulate contraction of your myocardium, and so you don't live for very long. If you chelate all the calcium, that's why EDTA is a poison. These tests that are done to measure the clotting times are really recalcification studies. And what that basically means is that when we collect blood on these patients, we collect it in a weak calcium chelator. Basically, we need to bring the calcium concentration in the blood down to under 1 millimolar, because that's the concentration that's needed to promote clot formation. So we typically collect blood in a blue top tube, which unfortunately I forgot to bring with me today. But they're tubes that contain a measured amount of sodium citrate, it's very important when you're doing clotting studies that those tubes get filled properly. They're vacuum tubes. So they're made to suck a certain amount of blood into the tube so that the amount of blood that's in there is correlated with the amount of citrate that's in the tube so that the final calcium concentration is where it should be. If you don't put enough blood in the tube, you have too much citrate. When you add calcium back to the specimen, you can't get it to the level it needs to be. If you add too much blood to the tube, you have too low a citrate concentration. The concentration in the tube is oftentimes, of calcium in the tube is therefore too high, and you will oftentimes get clotting occurring in the test tube before they ever run the specimen, which obviously doesn't help you very much since that's what you're trying to determine. It is very common, and I plead guilty to this when I was a house officer too. I don't draw blood on people very often anymore, so I don't get blamed for this. But the very standard technique for people drawing blood on patients is they take 20 different tubes and hold them in their hand, and they take a 50 cc syringe and draw blood, and then they stick the syringe into each of the tubes, and they put about 5 drops of blood in each tube. For doing a CBC or doing electrolyte studies, that's okay, because generally what's in the tube doesn't matter, but for clotting studies, you can't do that. You actually have to fill the tube to the appropriate amount in order to get an accurate result. When the lab sends you a notice saying that the specimen was QNS, or quantity not sufficient, that basically means you didn't put enough blood in the tube. It doesn't mean that they dropped the tube and broke it, although that's what oftentimes that's what people often will tell you why they didn't get a result. But there is a reason why they don't want to give out results in that setting, because the results are not reliable. Okay, so once we collect blood from people and you collect it appropriately, you spin down the red cells, the white cells, and the platelets so that you basically have platelet-poor plasma that's at the top of the tube, and you mix. You do a reaction mixture. Usually it's 1/10 of an ml of each of these in the reaction mixture of it's 2/10 of an ml of the patient's platelet-poor plasma, 1/10 of an ml of a combination of tissue factor and a phospholipid species, and this is for prothrombin time now. And then you add 25% calcium chloride, generally 1/10 of an ml. That will bring the final calcium concentration in the mixture to between 3 and 5 millimolar, and you measure the time it takes for a clot to form. That's how the test is done. And generally, for somebody who is not on anticoagulants and who doesn't have liver disease and doesn't have any other problems with their clotting system, the prothrombin time will generally be somewhere between 10 and 13 seconds. If it's not that, then you have to go through and figure out some other things about why it's not that. The prothrombin time measures this part of the clotting cascade, the extrinsic pathway. As I said, you add tissue factor to the reaction mixture. Tissue factor and factor 7 combine to form factor 7A, and that complex then binds to factor 10 in the presence of calcium ions and causes the formation of factor 10A, and then factor 10A combines with factor 5A and phospholipid, also in the presence of calcium ions, to form the prothrombinase complex, and that complex then converts prothrombin to thrombin, and thrombin acts on fibrinogen to form fibrin. And that's what the prothrombin time measures. And so it really looks at only the extrinsic pathway. It does not look at the intrinsic pathway whatsoever. It does look at the common pathway down here in order to look at the final formation of fibrin. APTT is done very similarly. Again, 50% of the reaction mixture is the patient's platelet or plasma. Instead of tissue factor, you have a 25% mixture of phospholipid and a highly negatively charged agent, which activates the contact portion of the clotting cascade. Most commonly, it's either C-Lite or kaolin that's used in this country. Again, you add calcium chloride to bring the calcium concentration to 3 to 5 millimolar, and you measure the time from the time you add the calcium to the time that you get a fibrin clot formed. And typically that is somewhere between 25 and 35 seconds, although it varies a little bit depending on the particular reagents that you are using. That measures the intrinsic pathway, and the intrinsic pathway is called the intrinsic pathway because everything that leads to clot formation is actually within the plasma itself. You don't have to add any protein components from outside. So it starts with factor 12, which is activated to 12A. That then leads to the activation of 11 to 11A. 11A activates 9 to 9A, and you can go down the pathway here, eventually to the common pathway, eventually down to fibrin formation down at the bottom. Now, factor 12, patients with low factor 12 levels, as you might imagine, if this is a cascade reaction, people with low factor 12 levels will have prolonged APTT values, oftentimes markedly prolonged APTT values, but interestingly, people with factor 12 deficiency do not bleed. In fact, the original patient that was described with factor 12 deficiency was a man named John Hageman. He, which is why factor 12 is sometimes called Hageman factor. But the only defect that he had in terms of his clotting system was that his blood did not clot in glass test tubes. Glass, as you probably know, has a high negative charge to it, so it will activate the clotting, the early part of the clotting system up here, in the same way that the reagents that we add to the test tube activates that part of the clotting cascade. Mr. Hageman actually died of a pulmonary embolism. He died of that after he suffered a major injury jumping from from one train to another, one moving train to another, I should say. Brains were not necessarily his strong point, but be that as it may. The APTT measures the intrinsic pathway here. The one thing that neither of these tests measures is the ability of factor 7A and tissue factor to activate factor 9 to 9A. This is actually probably physiologically the most important reaction in terms of the clotting process, and none of our tests measure it. And that's why a lot of the times these tests can be difficult. That's one of the reasons why these tests can be difficult to interpret, because it doesn't really measure what it is that happens in vivo. Also, they're being done in the test tube. You're not using platelet-derived phospholipid, which is a usual source of phospholipid that is present. That's present in the body, so that the values that you get may not match precisely what happens in a person. But they are the best approximation that we have without going into assays that are much more difficult to do and are almost impossible to standardize when you're doing large numbers of tests at one time. Now, what happens if you have an abnormality? How do you determine what's missing? And let me back up here. If any one of these proteins are missing, you will have a prolongation of one or both of the two tests that we're talking about. So, for example, if you are missing factor 11, factor 11 is only in the intrinsic pathway, so you will have a prolonged APTT value. If you are missing factor 7, which is only in the extrinsic pathway, you will have a prolonged prothrombin time. If you're missing one of the common pathway factors, factor 5, factor 10, prothrombin, or fibrinogen, you will have a prolongation of both times. And so now one of the important things to note is that 50% levels of any of the clotting proteins will normalize the particular time that you're measuring. So that if you have, you don't really usually work on determining missing clotting factors unless you have an abnormality in one of the screening tests. If the prothrombin time is abnormal, if it's only the prothrombin time, you will usually just look at factor 7. If the APTT is abnormal, then it's factor 12, 11, 9, or 8 that you typically will look at. If both of them are abnormal, then you're really looking at one of the common pathway factors, factor 2 or prothrombin, factor 5, factor 10 or fibrinogen. And so that's basically how you sort those out. And the way those assays are done is instead of putting into the reaction mixture 50% patient plasma, you will create a reaction mixture which is 25% patient plasma and 25% plasma that is deficient in only one clotting protein. For example, if you're testing for factor 8, you will use factor 8 deficient plasma, which is usually collected from patients who have hemophilia A, and it's standardized so that the only thing that's missing from that plasma is factor 8. When you do those assays, if you're doing a factor 8 assay and the patient is missing factor 8, they will have no factor 8 from their own plasma. They will have none in the factor deficient plasma, and so you will get they'll have none in the reaction mixture. You'll get a prolongation of that clotting time. And the degree of prolongation is actually proportional to the level of the factor that's present. If you're missing factor 8 and you're doing a factor 9 assay, you will get 50% factor 9 levels from the patient's plasma. You'll get 50% factor 9 from 50% factor 8 from the factor IX deficient plasma, and so you'll have at least 50% levels of both factors, and the APTT value therefore should be normal. And so that's basically how you determine which factor is missing. Doing those assays can be a royal pain in the neck, but it is something that's important when you're trying to sort out what the person has, because that also will determine what you need to give them to support their clotting. Giving factor VIII to a factor IX deficient patient in fact, not only does no good at all, but it actually is potentially dangerous, because it's potentially dangerous and it's extremely expensive. These products are unfortunately ridiculously expensive, and so you want to make sure you're giving the right thing to the right person. Now, if you have more than one factor level that's abnormal when you do those tests, it implies that you have an inhibitor to the clotting process, and that becomes a much more difficult prospect to look at. But typically your mixing studies will be abnormal. You need to make sure that you don't have any heparin present in the specimen, because heparin will screw up all of these tests. You shouldn't be giving heparin to somebody who has a bleeding disorder, except in the rare patient who has DIC anyway. And it's important to distinguish lupus anticoagulants from a circulating anticoagulant to a clotting factor. And the reason why that's important is that lupus anticoagulants are associated with thrombosis. Patients who have an inhibitor to one of the clotting proteins have a major risk of hemorrhage. And when I say a major risk of hemorrhage, I'll just give you a case that I saw now 22 years ago here, shortly after I arrived here. This 93-year-old woman came into the hospital with a spontaneous bleed into the chest wall, and had a prolonged APTT on her screening studies that they did. At that time, I was actually in charge of the special coagulation labs. I was down there doing something else, and the technician basically showed me the studies that she had done, and it basically said, the patient clearly has a factor VIII inhibitor. Who's taking care of the patient? They named one of the hematologists that was here at the time, and I said, fine, and left it alone. 4:30 on a Friday afternoon, which is when these things always happen, I get a phone call. Mrs. So-and-so is bleeding like a stuck pig. And I didn't know who Mrs. So-and-so was at the time, because I hadn't seen her. And it turns out that they had taken her to surgery to remove a lesion that was about a half a centimeter on the side of her face, away from where the bleed was originally, that looked like a squamous cell cancer. And so the ear, nose, and throat surgeons had taken her to the OR. They took this little thing off of the side of her face. She literally bled 50 units of blood from a lesion that was about a half a centimeter. That turned out to be scar tissue, incidentally. You don't want to do procedures on these patients because of that kind of risk. So you need to figure out what the inhibitor, what factor the inhibitor is directed against, along with what the titer of the inhibitor is, because that's important in terms of therapy. That's way beyond the scope of this course, but this is how you actually do those assays. You basically dilute out the patient's plasma until you essentially dilute the inhibitor out. So I just want to give you an overview of how these tests were done, so that it gives you some idea of how to interpret them when you get the results. I will send all this stuff to Betty later today, both yesterday's and today's, so you should have them by the end of the day. Yes.
Sure.
The difference between macrocytic and megaloblastic,
Okay.
is one in a category
Yeah.
of another? Okay.
Megaloblastic anemias are all macrocytic, but not all macrocytic anemias are megaloblastic.
Okay.
Megaloblastic anemia really refers to B12 and folate deficiency.
Okay.
But you can see macrocytosis from alcohol. You can see it from hypothyroidism. You can see it from liver disease. You can see it from certain medications. A lot of the anticonvulsants will cause macrocytosis. But megaloblastic anemia is a subset.
Okay. And then my other question was, since warfarin acts on so many different factors, do you see both the decrease in the PT and the APT, or mostly just the AP?
Actually, you see mostly an increase in the proton. We'll talk more about that on Monday when we talk about warfarin. But you use the prothrombin time to monitor warfarin activity, and that's because it's a more predictable assay.
Okay.
But in people who are on chronic warfarin, you see prolongations of both.
Okay. Perfect. Thank you.
Yes.
Very quick question.
Sure.
For 1 second. When I was shadowing the
Mm-hmm.
ER, I realized that when they order blood tests, they use different top
Mm-hmm.
colors for the top. I was
Right.
just wondering
What do those
they're
correlate
for.
to?
Yeah, I saw some of them they have citrate.
Uh-huh.
Some of them they have
EDTA.
EDTA.
Some have heparin. Some have
Right.
nothing.
Right.
It depends on what you're measuring. If you're doing blood counts, for example, you need the blood to not clot because otherwise all the cells get stuck in the clot, and so you never want that blood to clot. So you typically draw those in EDTA.
Do you mind if I take notes?
No. No problem. Have a good one.
I don't want to use the wrong one.
No, that's all right.
Write it down.
You will. Unfortunately, we all do at various times. But purple top tubes or lavender top tubes.
Purple, EDTA, or
Mhm.
CBC.
Right.
Yes.
Gold top tubes have nothing in them, and they are typically used for blood chemistry studies.
Oh, so BNC?
Yeah, metabolic panels, liver function panels, so forth. The blue top tubes typically have sodium citrate in them, and they're for coagulation studies.
So both APTT and PT is on that?
Yes.
Okay.
And actually a lot of the other coagulation studies.
So do we
Phone bill
use
is-
just one blue top tube and we can do all of them?
Well, it depends on how many tests you want to do. For a standard adult blue top tube, there's more than enough to do prothrombin time, APTT, fibrinogen, thrombin time. Basically, you collect about 3 mLs of blood in those. Each assay takes about 0.2 of an ml. So,
Oh, wow. 2.2.
right. So that if you
So that's like 15.
Right. So you can do multiple different assays on the same specimen. Don't forget, also, you collect 3 mLs of blood. That's probably 1.5 mLs of plasma
Oh,
because you don't use the red cells.
oh my god. This is like obvious thing, but you never think
No,
about
that's
it.
right. It's fine.
Now see, right, pink.
Pink tops also have EDTA in them. They're actually used in the blood bank. You'll hear more about that on Monday.
And I think I saw weird color like
Yeah, there's
gray.
a gray top have sodium chloride in them, and they're used for glucose, basically because they inhibit the enzymes that the sodium chloride inhibits the enzymes that metabolize glucose, so that you get an accurate level of glucose in those.
Oh, okay.
You can do glucose studies on gold top tubes as well, but if the tube sits around for any length of time, it'll continue to. Well, it's not so much as clotting as that the glucose that's in
that's in the plasma will continue to be metabolized by some of the enzymes that are in the plasma.
Right.
So, so if you want to do that, you use sodium fluoride. Their brown top tubes have sodium heparin in them, and they are typically used for like cell marker studies.
Oh, like cancer.
Yeah, a lot of the cancer marker studies.
Why do they use heparin in this case?
Because some of the assays that they use, heparin doesn't interfere with them, but EDTA does. Green top tubes use lithium heparin, have lithium heparin in them.
Yeah.
And we used to use those for electrolyte studies a lot of the time, but lithium can sometimes interfere with that, which is why we went back to using gold tops.
So the brown top has sodium heparin in it?
Right. Like there's a sort of it's more like a light tan as opposed to really brown. But yeah, the coating, the tops are really for coating for the whatever is in them.
Okay.
And since most physicians, I certainly plead guilty to this too, can't remember what's in the tubes, we usually wind up just doing it by what the color of the top is.
Yeah, that's what I think. When I order it, they will be like, I want one color of this, one color of that.
Right, exactly.
They never say what exactly.
Yeah, that's good.
Okay.
They're supposed to be standardized, that's why.
Yeah. And I remember there was an order, I think, where you draw blood.
Yeah, because you don't want to contaminate, particularly if you're doing clotting studies, you don't want to contaminate the tubes with heparin or with EDTA, because that will completely screw up the assay.
So if you want to order
One of
coag, you
one
always
of your
go
coags
with
first. It takes very little heparin or EDTA to mess up the coag specimen.
All right, thank you so much.
No problem. Yes.
This is kind of more of a random question.
That's right.
How long does it take? I was wondering how long it takes for, I guess, folate deficiency to actually manifest as some type of anemia.
Anywhere from, well, it depends on how deficient the diet is, but it's generally anywhere from 3 to 6 months.
Okay. And so that's just primarily through decreased synthesis of DNA?
Right.
Okay.